Oh, hey folks, I guess we're live. Let me just check YouTube here. Yep, it seems fine. It's it's rolling, it's happening, and it says it's an excellent connection. Okay. So, as I'm here back at my home office and we have a bunch of MRI and CT scans to report. I have maybe an hour until I have to leave for Jiu-Jitsu practice, BJJ practice, and we are going to report a few CT scans and MRI scans from the emergency, from the clinics. I have already downloaded a knee. Let me see here. No sensible data showing. And right there. So this is a right knee, a male patient, 59 years old, and it says there is arthrosis and free bodies inside the knee. So this can't be good. This is probably a completely screwed over knee, as always. So this is a sagittal PG, proton density weighted image. This is fat saturated, so we can actually see lesions as bright spots. Hey Tim, welcome. Nice. Let me just pop chat out so I can keep it right here by my side. And I can chat with you guys as I report. Yep, this is going to work. So, let's go. I made some changes to my transmission setup on OBS. I guess the audio is a bit better today. You guys, if you guys have any complaints about the audio and the video, just let me know in the chat. So, how's my screen share? It's sharing. Yep. There we go. So this is sagittal PG with fat saturation. This is sagittal T1. This is for morphology. This is for pathology. So I have a protocol for reading knees. I go from sagittal to coronal, and then I go axial. And on each sequence and plane, I tend to see particular lesions and presentations of diseases. So I'm just going to go through all that I can see on these images as I roll the images so you guys can tag along. First of all, there is edema all over the place. There's a small articular effusion, clear signs of synovitis. It's all blurred on the margins, and there is edema on the fat pads. Also, these are popliteal lymph nodes, quite common on these cases of acute arthritis. Patellar tendon is fine. Quadriceps femoris tendon is fine. This is very clear right here that I have patellofemoral arthrosis. There is thinning of the cartilage, some osteophytes, tiny osteophytes, and reduction of the articular space right there. So I have arthrosis right here. I can readily say the same about the femoral tibial, medial femoral tibial compartment right there, and not as much about the femoral tibial, lateral femoral tibial compartment. This is the fibula, so this is the lateral compartment. So I have arthrosis. I also have free bodies here and right here on the recesses. Let me just measure the largest one. It's 1.2 centimeters, 12 millimeters. And we also have a popliteal cyst right there. It's quite common on chronic cases of arthrosis and arthritis. And it's very clear to me right here that we have a partial lesion, partial tear of the anterior cruciate ligament. Right there. It's all fuzzy. It has hyper intense signal, and it's kind of blurred, especially on its distal extremity. So this is at least a level 2 tear, level 2 partial tear. Let me go for the coronal view. So this is the popliteal cyst right there, also called Baker cyst. This is a free body, another free body on the anterior recess. So there is thinning and partial rupture there of the fibers of the anterior cruciate ligament. It's quite clear right here. So this is a level 2 tear. As you guys can see, the cartilage right here is all gone. There are deep erosions of the cartilage, and it's very easy to see on T1 weighted images. Osteophytes all over the joint. I have superficial erosions right here, reduction in articular space, decrease in articular space. There is also subchondral bone edema right here, also right here too. This is quite common. This is all edema. This is quite painful. So I have mild arthrosis of the lateral femoral tibial compartment and moderate arthrosis of the medial femoral tibial compartment. Let's analyze the meniscus. I'll just grab the sagittal once again, and I'm starting off from the lateral compartment. So posterior, anterior portions or horns of the meniscus and the body of the meniscus. As far as I can tell, the lateral meniscus is fine. This is a deep erosion on the femoral cartilage right there, and a shallow superficial erosion on the tibial cartilage right there. On the other hand, let's see the medial meniscus right there. There is some irregularities and heterogeneous signal on the posterior horn of the meniscus, and it seems it's kind of thinned. It's a bit deformed on its body. I can see there is a amputation of the free margin right there of the body of the meniscus. This is probably a radial tear, and there is a clear extrusion of the body of the meniscus right there. So I have a very severe meniscal disease right there, which makes sense since there is arthrosis right there on the same compartment. So let's go for the axial view. We have arthrosis as well, erosion of the cartilage, decreased articular space, osteophytes. We have bone edema right there. Tendons are fine, collateral ligaments are fine, posterior cruciate ligament is fine. This is yet again the popliteal cyst, the Baker's cyst. Posterior tendons are fine. There is diffuse edema of the superficial soft tissue around the knee. Is there hypertrophy of the musculature? No. Muscles are fine considering the patient's age. We have this oblique sequence right here, which is unfortunately not fat saturated. I really don't get why people do this right there. It just makes no sense. You are supposed to evaluate ligaments and tendons with fat saturated PG or T2 sequences. But for some unknown reason, people just choose to make it wrong and do this terrible oblique sequences without fat saturation, which makes no sense and delivers much less very few information about the ligaments, especially the anterior cruciate ligament. So there is arthrosis, there is articular effusion, synovitis, there is medial meniscus tear and extrusion, there is partial tear of the anterior cruciate ligament, i.e. Baker's cyst, and edema of the soft tissue around the knee. So this is, as always, a pretty screwed up knee. I have a template for that. I'm just going to translate what I just said to Portuguese and finish this read. So you guys just bear with me for a bit and we'll be right on our way in just a few seconds. Yes, you did. You did, Tim. It's pretty messed up. Even on the X-ray, right? And you also told me that he had a knee replacement surgery on the other side, right? And he was supposed to be to get a knee replacement for the other side, and he just won't go to surgery. He doesn't want to. Oh, 2003? I mean, 20 years is more than enough to make a good knee, a bad knee for replacement surgery. I wonder how bad it is today on an MRI. Oh. So, so it's a moderate arthrosis, patellofemoral, and Femoral tibial, medial femoral tibial. Also, small articular joint effusion. Synovitis, Baker cyst, and free bodies, which are those calcifications we just saw. Partial anterior cruciate ligament tear. And edema. And this is more than enough. Let's go to the next one. So I'll grab another CT scan and then another MRI scan, and then we can go to the MRI, the CTs. There are a bunch of CTs already from the emergency, and we could just have a little fun with that. Let's go. Let's download. This is a 57-year-old male patient. He had a right shoulder MRI, and it says he has suffered a motorcycle crash and a shoulder fracture and a clavicle, which is the collarbone fracture, and ribs and all that good stuff, plus a bunch of tendon ruptures. He never got surgery, so we are looking here at a probable screwed over shoulder. So this is a complete mess of a shoulder. This is coronal. This is axial. I like to start like that. So that is a bone edema on the major humerus tuberosity. This is a PG with fat saturation. Clear rupture of the glenoid labrum right there. I see it on the axial view. Yes, kinda. I can almost see that on the axial view. It's enough. I feel like there is a thinning of the biceps, long head biceps tendon right there. See? Can't really tell for sure. Let me see if I can see it. By the glenoid labrum, I can't really say. Yes, it's supposed to be right here, but it isn't. There is some fluid right there. And when I go over, this is the supraspinatus right here. And right below it, there should be the long head biceps. The tendon of the long head of the biceps. And there is none. This is the proximal, the distal tendon, it's ruptured, and the bicipital sulcus is all empty, just some liquid right there. So we have a complete tear of the biceps tendon, the tendon of the long head of the biceps. So there's some degenerative disease of the superior and anterior glenoid labrum right there, some bone edema, no effusion, but there is a clear distension, liquid distension of the subacromial subdeltoid bursa right there. There is a really severe tendinosis or tendinitis of the supraspinatus, right there. It's not quite as bright as liquid, so I can't really say this is rupture. There is some sort of tendinosis of the subscapularis, and of course, a tiny tendinosis, very mild, of the infrascapularis tendon. Infraspinatus tendon. Also, let me see the acromioclavicular joint. So we have a acromio bipartido. I don't remember how to call it in English, but this is a anatomical variant right here. It's prone to degenerative disease, as it is. Or maybe this is a fracture. It's some kind of an old fracture of the clavicle. Yeah, this is just, no, this is a pseudoarthrosis of the clavicle. This is the clavicle. No, this is acromion. Clavicle is right here. This is kind of twisted. Yeah, the clavicle is here. This is the acromion. Patient is kind of twisted. This is the, yeah, this is scapula. Yeah, this is acromion right here. This is scapula. Yeah. Oh, how do I call acromio bipartido in English? I can't remember. Oh, it's os acromiale. Oh. Which is by itself Latin. So there is no direct translation as far as I can see here. Yeah, and Radiopedia also calls it os acromiale. Yeah. So this is prone to arthrosis, just as we see right here. So there is os acromialis, and right there, the edema is black on T1 weighted images. So we have the rupture, complete tear of the long head biceps tendon. Also, we have degenerative disease of the labrum. We have some bone edema. We have a severe tendinitis of the supraspinatus tendon. Of course, it's tendon, it's tendinitis. Mild tendinitis of the subscapularis and the infraspinatus, and also arthrosis and os acromiale. I might be pronouncing that wrongly, but this is as much as my Latin skills go. Also, we have hypertrophy of all muscles of the shoulder, subscapularis, supraspinatus, and infraspinatus right there, and the teres minor is kinda normal. Also, there is some signs of vicious ossification. Maybe this is an old fracture right there on the body of the scapula. Yes, there is some irregularities right there. These are old fractures for sure. There is the the coracoid process is right there. This is a very the patient is malpositioned in a very peculiar way. Let me see. The coronal is fine. The sagittal is fine. But it looks very odd. So let's report it. Shoulder. Let's get the shoulder. I have a template for a shoulder with disease, so we can type it faster. Well, the scapula has signs of old fractures and some deformities. There is arthrosis of the acromioclavicular joint. No articular joint effusion. The glenoid labrum is not okay. Tendons. And complete tear of the long head of the biceps. And muscular hypertrophy. So this is a chronic shoulder, just as we anticipated because of the clinical history they told us. They wrote about on the exam order. Just finishing up. Subscapular. Yeah. This is the one of the possible worst case scenarios for a shoulder MRI. So let's send this in and let's go to the emergency. There is 58 emergency CT scans on the list on the queue for report. Let's grab the first one. It's a abdominal CT scan. It says abdominal pain, of course. 60-year-old patient, and he has a stomachache. This is probably an unenhanced CT scan. I'm just going to grab. Yeah. ER is fun. Let's just load the images right there. So we have some lung disease, pleural disease right there on the right. This can't be good. This patient is quite old, and the ER is the ER right there. So let me just grab a template. I have a template for old patients from the ER that get abdominal CT scans. He has a long dwelling catheter right there on his superior vena cava. This probably is a oncologic patient. There is diffuse edema of soft tissue all over the place. This can't be good. There is at least a moderate pleural effusion on the right lung, and atelectasis, probably consolidations on the left, on the right lower lung, also a mild pleural effusion on the left, right there, with corresponding atelectasis of the other lung. Oh boy. Let's go. So indeed, there is distension of the colon. This is as bad as it gets. There is a catheter on the urinary bladder. They didn't scan the patient all the way to the end of the rectum because reasons. They just scan as much as they want. They couldn't care less about proper scanning, so they just do it like that. There is a hyperdistended gallbladder with a stone, partially calcified stone, at least one right there. So this by itself could be a acute biliary abdomen right there. That is a very large, huge ascites, whatever it's the right pronunciation. There is diffuse thickening of the walls of the urinary bladder and some kind of hyperattenuating component on its insides. This is probably blood or residue from some other radiological contrast enhanced exam. Let me just measure this gallbladder right here. It's 67, so it's clearly hyperdistended. Pancreas is partially fat infiltrated, but otherwise normal. I have mild atherosclerosis right here of the aorta. Adrenal glands are fine. Diffuse stranding of the intracavitary fat. Diffuse stranding edema of the superficial tissues. Oh God, I just hate this partially scanned abdomens. Just hate it. It's not difficult to do a proper abdominal scan. Just scan the freaking patient. For God's sakes. Just makes no freaking sense to end this scan right there. Just stupid. It's really stupid to do that. You guys go all the way to the proximal, the superior portion of the chest, which makes no freaking sense. They just can't do a proper pelvic scan. You just can't do it. It's just that stupid. I can even see the prostate and the the pelvic floor right there, not the end of the rectum. It's just stupid. It just makes no freaking sense. Can't just send a scan like that over for reporting, but it is what it is. It is what it is. So we are going to report this as a acute calculus cholecystitis. This is an acute inflammation of the gallbladder and a severe ascites, mild atherosclerosis. There is a malpositioned probe right there. It goes through the prostate into the vesical floor, and there is maybe some sort of blood or bloody content inside this very thickened urinary bladder. There is also distension, gas and liquid distension of the colon. And this is it. Kidneys are fine. Spleen, as much as we can see. And the liver is just not sick enough to be of importance. Diffuse edema. Also, the field of view is wrong. It's too small. Patient is too shaky. There is no contrast enhancement. So this is a terrible scan, as always, from the emergency. This is crap. But we can make some sort of diagnosis, of course. So I'm just going to write that down. Oh yes, this is an stomach ache. You guys could do better than that, but you just don't make a slight, a just tiny effort to make it any better than that. That is lymph node enlargement. Right there, I just measured one of those lymph nodes. It's 1.6 centimeters on the short axis, so it's indeed enlarged. It is a very profuse, very large, huge increase in intraperitoneal fluid. It is ascites or ascites. I can't really tell how I'm supposed to pronounce that. I guess it's ascites, or I guess it's ascites. It's ASCITIS. Guess. Hello, Holden. How's it going? Are we done? Oh. Now we're done. Let's go. And this one. And the next one should be a chest CT scan. So let's grab a chest CT scan and download it. This is a 42 male patient. It says he has been losing weight and he has a left lung lesion. Hey, nice. So it's here. Yeah. This can't be good. You guys must be having fun. This is a nightmare. Right there. Bronchiectasis. 3 in bud. Lesions all over the place. Oh crap. This is terrible. This is some kind of acute disease with a pulmonary distortion, both parenchyma and airways, and it's spreading through the airways and it's obstructing the smaller airways, just like that, just like that. Considering we are in Brazil, this is most probably a case of tuberculosis, post-primary tuberculosis, bronchiectasis, small consolidations, pulmonary bands, micronodules with 3 in bud morphology, much more prominent on the upper lobes, and the patient has been losing weight. So yep, it is 3 in bud. I'm just going to close up on it so you guys can see, or check that out. 3 in bud presentation, classic 3 in bud presentation. So in this particular case, I suppose this is a mucus obstruction of small airways. And of course we have bronchiectasis and small consolidations with cavitation or excavation, which is necrosis. So right there, consolidations with necrosis, bronchiectasis, and all that good tuberculosis stuff. Yeah, it's for a 42-year-old male, this is a very bad sign. He is going to have a bunch of residual disease for sure. There is calcification, residual calcification. There is lymph node enlargement, right there on the aortopulmonary window, paratracheal, subcarinal, right there. So we have all we could be expecting from a case of active pulmonary post-primary tuberculosis. I'm just going to do an APR right here to look for bone anything, because bone could be surprising. So there isn't much. So necrosis, excavations or cavitated consolidations. There, this is a very peculiar morphology for this area right here. Kind of ground glass with the bronchiectasis and the small nodules and the micro nodules with trim bud. Let's report it. Because as you guys know, unfortunately, exams just won't report themselves. AI won't help us on this case. Just good old keyboard and radiologist typing those very fancy words in the report. Right there, I have a template for this, of course, as always. So, really? They took 9 vials of blood for a TB test? But we don't really do blood tests for TB in Brazil. You actually do a skin test, which is called PPD. It says it shows if you have already been in contact with the bacteria, the bacillus, and we also do a chest CT or X-ray to look for active disease. And what else we do? We do a test. We do a test if the person is coughing and he is producing bloody mucus, or at least some kind of mucus. You can test the mucus and do a direct test for the tuberculosis bacteria, and also you can get a culture. You can cultivate the mucus on specialized material in the lab to confirm that is tuberculosis. But we usually do imaging scans and the skin testing, and we the physicians are used to do a treatment test, and they put the patient under treatment for tuberculosis when they are quite sure the disease is there, especially on image scans, right, like this one. And with positive epidemiology such as mild fever and weight loss, and it's what it takes to make the diagnosis. It makes no sense. Oh, this kind of job admittance, job tests, tests to they require for hiring you for a job. It makes no sense because you have no signs of such disease. It shouldn't be done like that. If you go through a family doctor to assess your health. You shouldn't do any tests for a job application to be hired just because they want to do it, because it makes no sense to do tests with no clinical background that would make those tests have any meaning or purpose. So it's just bureaucrats being bureaucrats. There is no science in that, no logic even. So let's report this. So there is lymph node enlargement. How large was that? 1.3. So we are almost done. Ooh. These leap years always. It is really stupid to draw blood for that. And people are quite afraid of tuberculosis because it's so easy to treat. And usually it's a poverty disease. It's a poverty related disease, at least here in Brazil, because you are supposed or expected to be malnourished and living in very unhealthy conditions to actually be susceptible to tuberculosis, unless you have some kind of immunological disease or HIV, HIV/AIDS, because without treatment it gets immunocompromised. But unless you are very poor and very malnourished, you aren't supposed, or very old, or going through some kind of immunosuppressant or treatment, or immunocompromised for some reason, you are not supposed to have tuberculosis, active post-primary tuberculosis. So you, Tim, just, it makes no sense to expect you to have such disease. It's just stupid, just unscientific. It makes no sense in a medical setting, in a rational medical reasoning. It's just bureaucratic stupidity. So let's say I'm just speaking my ass off. I have to work. Let's go. This is done. Let's grab another CT scan. This is the abdominal CT. Yeah, I'm going to download it. This seems to be contrast enhanced. It says this patient has lymph node enlargement on the axillary regions and on the inguinal regions. And they ordered a abdominal CT scan, and it has no contrast enhancement. Oh. Someone is already reporting this. Oh, in prisons it makes sense. It makes sense to be common in prisons. Here too, it's quite common in prison. This in Hansen disease, which is lepra. Lepra em português ou hanseníase. Lepra. Let me see how hanseníase is pronounced in English. It's leprosy. Leprosy. It's another mycobacterium infection, quite common in patients like this, like that. Really? Man, they are into that crap. Makes no sense. Come on. So I just got another abdominal CT scan. This is a 58-year-old male, and he has a left-sided abdominal pain. So this is unenhanced and has no clinical data that we can make some sense of. Oh yes, of course. Come on. This is right there. Left-sided indeed. I agree. There is left-sided abdominal pain for sure. Again, and I'm pretty sure you guys have already seen the motive as much as I have. This is an old CT scanner, so we can't expect much, but we can readily see right there on the terminal inferior ureter, left ureter, there is a kidney stone right there. It's almost 1.5 centimeters to the inside of the bladder, and it's a micro stone. It's a 0.2, 0.3 stone right there. And if we scroll back up, there is mild dilatation, mild hydronephrosis, and yet another stone right there, which is 6 millimeters, 0.6 centimeters. And I'm going to zoom in to measure its attenuation to see how hard it is. It looks not that hard. 200, 225. This is probably due to the bad quality of this exam. It's around 200 Hounsfield units, not much, kind of soft. But the motive for the pain itself, it's right there. I can see the liver, it's a little less attenuating, a little less dense than the spleen. So this is 52 and this is 57. Oi.
O senhor viu o bucal?
Não, não vi.
Tu tem algum short sem bolso?
Acho que tem lá no meu armário, amor. Senão você pode usar o seu.
O que é que eu sou hoje?
Vixe, tá quase na hora da gente ir, né?
Eu vai ter short. Mas não é a mesma hora?
Não, é 4 horas.
É que hoje o tio disse pra você não vir.
Tá bom, eu já vou me vestir.
Vou pegar um de quarto. Você tem dois e só um.
Pode pegar o que você encontrar lá, meu amor. So guys, I have to get to BJJ practice. My kids just got here and remind me of it. I'm just going to finish this scan. So this is steatosis and a left-sided ureter stone right there. If you guys enjoyed this video, just hit that like button and consider subscribing to the channel. I'll be around soon for more live streams just like this. Thank you so much. See you guys around.